it's just a huge honor for me today to be podcast interviewing Rich Hirschinger all the way from Beverly Hills, correct?
Correct.
And Beverly Hills, California. And you must be a glutton for punishment because you went into oral facial pain. And that I think most people would never want to. I think I might become a pediatric dentist before I became specialized in oral facial pain. Rich is in private practice treating patients with oral facial pain and obstructive sleep apnea at his office in Beverly Hills, California. He graduated from the University of California School of Dentistry in 1985 and practiced dentistry for 10 years, after which separate hand and back injuries forced him to sell his practice. After receiving a master's in business administration from USC Marshall School of Business in 2001, he founded DDS.com and DMD.com. After a few other life-changing events, he completed a 2-year full residency in oral facial pain and dental sleep medicine at the UCLA School of Dentistry in 2012 and became a diplomate of the American Board of Oral Facial Pain the same year. In 2013, Officite acquired DDS.com, and Dr. Hirschinger was the first member of and serves on the professional advisory board of the company. He started his private practice in May 2013, serves as a clinical co-director at UCLA School in Oral Facial Pain and Dental Sleep Medicine Residency Program, and he is a fellow of the American Academy of Oral Facial Pain in 2014, and he practices without a high-speed handpiece and does not need to touch the teeth to help his patients. Now tell me this, Rich. You got out of dental school in 85, I was 87. When did you really first hear of sleep apnea, obstructive sleep apnea? Now it's all the norm, 30 years later, but when did this start to bubble up to the top?
Well, for me, I was out of the patient practice side of dentistry for over 15 years. So I wasn't, really involved. When I was doing websites for dentists, I probably, in the mid 2000s, late 2000s, doctors started to add sleep apnea to their website. And that's when I really kind of became aware that it was something that dentists can actually treat.
About what year was that about? When they started?
Mid 2000s, late 2000s for me.
So 2005?
Yeah.
Okay, so about 10 years ago. So walk us through that story. What was DDS.com and why did Officite buy DDS.com? It's a website development company?
Yeah, basically it's, online dental marketing. We did websites when we first launched in 2002. It was just about a website. There weren't any mobile phones. People weren't blogging yet. And then when people started blogging, we added blogs. Then we added, reputation management, mobile websites, and all the various features you had to have, basically in order to do dental marketing. I would get 4 or 5 emails a week from various people that wanted to buy just the domain, DDS.com and or DMD.com. Most of the offers were just people fishing very, very ridiculously low offers. I had one company that took a pretty serious run at me. It just wasn't enough to make me want to sell. And then Officite came along with a very, very legitimate offer in late 2012, and I accepted and sold the company in early 2013.
So where's Officite out of?
They're based out of Downers Grove, Chicago.
Chicago.
Downers Grove, Illinois, which is a suburb of Chicago.
So, and you still do anything with Officite? Or, are you involved?
Yeah, I gave a lecture on their behalf at the Connecticut State Dental Association meeting this past May. Talked about, actually spoke with an attorney, which was a very interesting experience. We spoke a lot about reputation management, what you can and can't say about negative reviews, and what to do about it when you do get one.
Yeah, dentists are kind of, well, the social animal human spends too much time thinking about what other humans think. And I don't have thick skin. I just don't have the time to ever think or care what other people think. I think it's so silly when these dentists, they get a bad review and it's like someone hit them in the stomach with a baseball bat. And it's like, dude, there's 7.5 billion talking monkeys on Earth, and 100 billion human beings, sapien, have been born and died before today. 100 billion. And there's 7.5 billion today. You really care what 107 billion talking monkeys ever thought or said about you? I think they're too thin-skinned because they spend too much time worrying about what other people think.
I think that's why people really enjoy hearing you speak, because, like you said, You don't care. You'll tell it like it is. You'll say it like it is. And I think that's one of the things that's made you successful.
Yeah. So, but before we get into oral facial pain, did you want to talk about the state of websites today, since you have a distinguished background in that also? Or would
Oh,
you rather go into oral facial pain?
oh, it's up to you. It's interesting to me because, obviously when I launched the company, it was all just about a website and that's all you needed. And now having a website now is just not enough. It has to have certain features. One of the things that everybody should absolutely do is make sure their website is what we call a responsive design. So you can tell that if you take a regular browser, whether that's Chrome, Firefox, Safari, and you have a large window and you shrink the window down and make it very, very narrow, does that design change? Because that's what you're going to see on your mobile phone. Google actually made an announcement, which they rarely do, but I think it was around 2015 where they came out and made an announcement saying, we're adding this to our formula, we're adding this to our algorithm of what we consider important so that your design is responsive, so that you have a site that basically has one design, but it looks good on a mobile device, looks good on a tablet, looks good on a laptop or desktop, and it'll basically respond to the width of the screen.
Yeah, and Rich, I get a gazillion emails a day, and when I reply, a lot of times I want to know who I'm talking to, so I'll drop their name in, go to their website. I am, first of all, I'm just flat out shocked how at least 20% of the dentists don't even show up on a website. I mean, you cannot find them on a website and try their names and all that. And then the other ones, I mean, it looks like their eighth grade daughter made it in for some science project class. Just text. I mean, you just rarely see a great website. And then when you meet a dentist, Southwest Airlines gave every American the freedom to afford to fly. And these dentists that are doing their websites doing a bunch of implants or cosmetic or specialty work like you, oral facial pain, and they'll have a rocking hot website and they'll say, oh yeah, people fly into my office from 4 different states because it's not that expensive. I mean, when I was little, every time I would talk to my grandma on the phone, my mom would be in the background yelling, it's 10 cents a minute, it's 10 cents a minute. And now anybody can talk as long as they want. And same thing, when you were little, only rich people flew on an airplane. Now anybody can afford Southwest Airlines. So websites are so important, and I don't ever want to talk about it. And by the way, this month's column of mine on Dental Town was, what does your website say about you? I would give anything for you to go in there and reply in the comments your thoughts on that, or maybe forward that article to anybody that you know at Officite that can add value, because I mean, I feel embarrassed that I had to write a column on website design in 2016, but my homies, I mean, they don't get it.
A lot of people, when I first started, people would walk by the booth and go, website, I don't need that. Email, what's that? I don't have this. And I said, well, that's to the benefit of all of your colleagues. The ones that do are going to get those patients that are looking for, providers online. And I actually had an interesting experience just about 10 days ago. I'm an expert witness for oral facial pain. I was just an expert witness for a dentist who, against my advice, started a search engine optimization company with a couple providers. I told him I really didn't like what they were doing. I didn't think they were doing it correctly. Ended up, the company broke up after about a year, and then his old partners ended up allegedly taking his website, and he dropped off the first page for a very, very highly competitive search term, and it cost him hundreds of thousands of dollars. And it's interesting, trying to explain this to a judge who is very, very non-technical to get her to understand the lingo. But as you said, it's really important. I think a lot of dentists are afraid to always, quote unquote, advertise. And to me, there's a huge difference between advertising and marketing. Advertising, to me, typically has dollar signs associated with it. Marketing is just letting people know what you do. I do crowns, bridges, veneers, implants, whatever it is. That's just a way. And people are online looking for this. And now they're using their mobile devices more than ever. So getting back to what I said before, if your website's not mobile responsive, you're really missing the boat.
Well, it's I personally believe in a social animal like humans, only 1% feel totally comfortable flying above the radar. And 99% just don't like to draw attention to themselves. They don't like transparency. They don't like checks and balances. They like to be in a cave. And then so they, yeah, I mean, remember Bob Ibsen who owned Denmat
Yes.
and Rembrandt. He passed away last year. I mean, trying to get him to do an interview, anything that involved Bob Ibsen, he would run the other way. I mean, he just want to run and hide, um, and it's just crazy how that works. I want to ask you one website question though that seems very controversial. Some people say don't put any gory pictures. I mean, if you're placing implants, don't show any blood and guts and an implant coming out of a jaw. And then other people like to show on their website, close up pictures of edentulous implants coming out. What's your thoughts on pictures? I mean, should they only be like iPhone pictures that their friend would take in a selfie, or do you like some close up shots of the actual dentistry and root canals and the bloody gory stuff?
We actually did some research with patients. I always say, the website's not for the doctor, it's not for the staff, it's not for the team. It's for the patients and prospective patients. And patients don't care about that. They don't want to see blood and guts. They don't want to see anything that they perceived as even possibly causing pain. So even a photograph that just has the lip spreaders in it, which you and I know doesn't hurt at all, they kind of cringe. So always try and think of, look at your website from a patient's point of view. There's something we call the billboard test, which is take a step back. And what do you see when you're stepping back from afar? And if it's something that you think might possibly turn off even someone from calling your office, don't put it on there. So I always recommend it, definitely always have a smile in there. I always like to have my before and afters really legitimate, meaning, I hate seeing the befores where they look depressed, there's no makeup, they just got out of a car wreck. And then the before, they got full makeup, they've had, the full makeover, and it looks fantastic. I like it when it's nice and representative. One of my friends and colleagues, Bernie Villadiego, is just right on. He's a phenomenal photographer, and he really learned. He considers himself an amateur photographer. I consider him to be a professional. He takes phenomenal photos, and they're very, very real. And he's comparing apples to apples, and he's not trying to do any trickery with anything other than what he's trying to present with the before and after dentistry.
Yeah, a lot of bodybuilders want to hire me as their before picture, and I get requested all the time. Another problem with dentists on their websites is one of the biggest job destroying technologies of all time was the answering machine. And about 3 million secretaries lost their job because basically they were taking messages while someone else was on the phone. And dentists are still enabled. Every dentist in America has a front desk receptionist. So many of my friends, I'm 54, so many of my friends that are dentists my age pretty much are not even on Dental Town, the internet. And I'll say to him, well, if you wanted to buy a book on Amazon, would you do? And he goes, well, I'd write it down on a post-it note and go give it to Emma, and she'd order. Well, when you go to Townie meeting, how do you do that? Well, Emma does the whole thing. I have no idea what she. So I think a lot of these dentists, the reason their websites are so horrible is because they're not even website connoisseurs themselves. Now, millennials would be a whole different bag of wax, but I think so many of the dentists wouldn't even know if they're 50 to 70, you'd be stunned at how many of them are never on the internet. In fact, my sons, their grandpa, his wife was the secretary of the front desk of their business, and so she did all the typing. And when the internet came out, he just saw the whole thing as a typewriter, and he goes, "No, Doris does all the typing." So he missed the whole internet because in his walnut brain, he just saw the keyboard and he thinks it's a typewriter. And so many dentists, believe it or not, are in that realm.
Oh
Um,
yeah, I remember there was dentist that came by my booth. I think it was the ADA in 2005. I don't know. I don't know why I remember that. It was in Philadelphia, so whatever year that was, and liked what I was offering, and said, this isn't for, I'm not trying to attract patients. I'm in the mid-city of Philadelphia. I'm just 100% referral practice, and I want to put some of my before and after cases and just kind of let my patients know what I do. And I said, great. So he signed up. And I think it was within about a year, I got an email from him. He was stunned that he was getting about 30% of his new patients from the web. He wasn't even trying and didn't think that was going to be the right outlet for him because he wasn't trying to target a web-based audience. And phones started ringing. So
What do you think of these other companies? Like, there's a guy out by you, Randy Alvarez. Have you heard of him? Where dentists fly down and he kind of interviews them like they're on television, a fancy desk and all that stuff. And dentists put that on their website. Have you seen that?
I've heard of him. I haven't seen any of his
Well,
work.
well, well what do you think is the importance of when you go to the website to have a video? Maybe it could just be an uploaded YouTube video of an interview with the doctor, so they see the doctor talking, all that kind of stuff. Do you think that's an important
I
part
think
of a website?
uh, I think it really comes down to the doctor's personality. If you've got a good personality and that can come across on the web, use it to your benefit. If you are just going to be so terrified and camera shy and you're going to look awful on video and kind of stumble your way across any type of interview, even though you can edit it however you want, then don't do it. I think it's just a website to me should definitely reflect the personality of not just the doctor but the entire practice.
And so, where's Officite's? What's their unique selling proposition in this uh, dental website market space? What separates them from the pack? How are they doing? And
Oh, I think a lot of it is just based on content. When I've always said anybody can go out and create a website, and you can have a graphic designer say, I want it to be blue, pink, yellow, red, whatever colors you want, and you have a beautiful design. But then you have a website. And is it what I call either a brochure website or a educational informational website? Meaning, is it just, here's my office hours, here's where I'm located, here's a little bit about me, maybe about some of my front and back office team members, and that's it. There's really no reason for the patient to ever come back and look at the site again, versus a website that's very, very content rich, where you can review some of the procedures that they need, crowns, bridges, veneers, whatever it is. And when the patient leaves the office, you can either follow up with them by sending links to cases of Mrs. Smith. This is a combination case where it was a case I did with implants and veneers. We worked with a periodontist to do grafting, or if you have a laser in your office, whatever it is that you can show off either the type of treatment that you provide or in combination with other specialists. If that's on your site, it kind of makes you an authority. If it's just a brochure website, they're not going to look at it more than once, and they might actually look and pass and try and call somebody else.
so I got the perfect segue from Officite to oral facial pain. Is it true that 85% of the people searching websites and calling dental offices is women? And is it true that 85% of the patients seeking treatment for oral facial pain is women? Are those two numbers about right?
You're awfully close. I've always said right around 80. So 80,
For both
85%.
for both the website and oral facial pain?
Yeah, it's uh, there's different theories of why more women are in a facial pain practice than men. None of it's been proven, but people have just different theories.
Mine is that they're batshit crazy. Am I close? Am I
Well,
close?
what most of us will say is we've got a lot of headaches because it's men that are causing them.
Well, it seems like most people have said on this show that women are just more prone to seek treatment. I mean, we all have the grandpas and the uncles who you hear people nagging at them. You need to go to a doctor. You need to get that checked out. And they never do anything. And so I think do you think a big part of it is that just women are asking directions? I mean, I can't tell you how stressful it was to be when we drove from Wichita, Kansas to Disneyland, and my dad got into LA, and my dad he'd shoot himself before he'd ask for help. And and mom's just looking at us 7 kids like, I'm sorry, your father's an idiot. I mean, so men don't ask for directions. They don't want to talk to a doctor. I got 4 boys. I mean, every time they ask me a medical question, I say, "Well, come on, let's make an appointment. I mean, our doctor's right up the street. Let's no. So is that a big part of it, or do you think the hormone, the estrogen, is a part of it?
Yes, all of it is, in the sense that women clearly have a higher pain tolerance than men. I think if you asked most men if they could ever birth a baby, we would be wimps, and we probably wouldn't be able to do it. But women are more opt just clearly to seek treatment if they've got a pain. They're not going to typically say it's going to go away. They might recognize clearly when something's wrong, and if it's not going away, they're going to seek treatment. Is there a relation with hormones? Absolutely. And there's so many different factors. We just really, really don't know, what the cause is.
Yeah, I thought my number one, if I tripped over Genie and got just one wish, it'd be to bring Dr. Lamaze in my office, and I'd pull all 4 of his wisdom teeth while he just held his wife's hands and just breathed, and I'd be elevating those wisdom teeth, saying, "It's just pressure. It's just pressure. Just breathe. Just blow." Oh my God, I want to pull those guys' wisdom teeth with no anesthetic. I mean, if men were having babies, we'd be on an OxyContin IV drip. We'd be knocked out. We'd be unconscious. And only a man could convince all these women to have their babies naturally. I mean, what is naturally? A tornado, a hurricane, an earthquake? I mean, yeah, that's crazy. I'm going to go. This is Dentistry Uncensored. I don't like to talk about anything everyone agrees on, but when you go into oral facial pain, on TMJ, TMD, whatever you want to call it, there are hardcore people like Peter Dawson, who still is alive and preaching that it's all occlusion. And then there's other people who say there's a psychological component to it. And those camps they do not agree with each other at all. I mean, they're both set in stone. So who's right, Dawson or psychosocial? Is the is it 50 Shades of Gray in the middle?
There was actually you had a podcast on last week, and I watched some of that the other day, and it was a neuromuscular dentist, and I actually was very curious myself to learn about that, and I think it was in 2012 after I finished my residency of spending 2 years without touching teeth, without lifting a handpiece, without trying to find that lateral interference on a certain cusp to figure out, why that's causing their pain. And I went to an ICMO meeting. It was actually it was in Phoenix or Scottsdale, somewhere like that. And I went very respectful. I didn't, wasn't there to cause any problems at all. I just wanted to kind of be there silently hide, go to the 3D
What meeting was it? ICMO?
The ICMO, the ICCMO.
ICCMO, what's that stand for?
I'm not exactly sure the acronym, but it's a neuromuscular dentistry group founded by Jankelson.
Oh, okay.
It's all about occlusion. It's all about essentially the condyles in the wrong position. We have to move everybody down and forward. We've got to give patients a splint to wear, nightly, 24 hours a day for 3 months, and then when you take it out, they're supposedly more comfortable, but their occlusion is totally changed. So now there's a phase 1, which is the orthosis, orthotic, whatever they want to call it. Then there's the phase 2, which is either now you get to sell them either a very expensive full mouth rehab, or you get to sell them orthodontics, or if they really want to kind of put their foot in the ground, patient can say, no, I'm fine wearing this removable appliance or this appliance I've got to wear every single day the rest of my life. How can people that do what I do, that don't touch teeth, that don't have patients ever wear an appliance 24/7, I just only have my patients wear an appliance at night, how can we do what we do without touching teeth? And we're treating pretty much the same patient pool. And it doesn't make any sense to me at all. And I went and I looked at all the K7s and the mile monitors and the TENS units. I love technology. I don't need any of that. And when I've spoken to some of these dentists, even locally, there was a neuromuscular dentist here at a continuing education meeting. We were talking, and he says, how do you treat migraines? And I said, he goes, with medication? And I said, typically, yes. And I said, well, how do you diagnose a migraine? And he was kind of a little bit of a deer in the headlights. He goes, well, I'll hook him up to a K7, my mile monitor. And I said, no, what questions do you ask the patient to know if they have a migraine? The International Headache Society, people that treat headaches all over the world, have come to a consensus that these certain criteria are, required to treat, to call it a migraine. So he wasn't even sure what kind of headache he was treating. And a headache is not a migraine, and not all, patients that have a headache have migraines. So there's, to me, I've gotten in trouble in the past on Dental Town. I said something one time. We were in a forum, and I said, "Well, you guys think with a handpiece, and I think with my brain." And that caused a huge backlash. And I said, "Okay, guys, I understand. Let me take that back. Not take it back, but let me rephrase that. You guys think with a handpiece, and I think without a handpiece." And I think that's the biggest difference. Is I'm not looking to to treat teeth. These patients with chronic pain, if they're walking around with their teeth together during the day, they shouldn't be. So keep your teeth apart. I know that teeth touch a couple thousand times a day when we swallow, but it's not a full maximum intercuspation. It's a light little touch. And when you chew, there's food in between the teeth, so your teeth aren't even touching them. And for these patients that have a problem, most of them need, I just make a full coverage, flat, hard plane splint. I typically make it on the mandibular arch. Patients find it a little bit more comfortable. It's a little bit more smaller, doesn't take up the airway. And I just let them slide around. And I'm not looking to try and change a bite. I'm not looking to try and change the position of a condyle. And one of the biggest things is when patients come in, most patients come in that have TMJ, and I always go, point with one finger where your pain is, or you can point to multiple spots, but just point with a finger. They're giving you the diagnosis. They're pointing to either the superficial masseter or the deep masseter as the source of their pain. It has nothing to do with the bite. So that's why I really disagree with the full neuromuscular approach, or any approach that really is doing surgery, which if you're taking a burr to enamel, that's surgery. You can't put that enamel back if the pain doesn't go away.
Well, it reminds me of when the orthopedic surgeons went ballistic when the federal government, Medicaid, Medicare started covering chiropractic care, because the Congress, that they were looking at this stuff saying, well, every time we send you a patient, you fuse 4 discs together and charges $50,000, $75,000, and 5 years later your patients are still in pain. And the chiropractors, they see these patients, they don't do any surgery, they're only charging us $2,500, and they have better outcomes. And so if your only tool is a hammer, everything looks like a nail. So a dentist is a full-time surgeon in an operatory, and he wants to lean everybody back, and then she wants to drill on all his teeth. And the reason I never understood those a lot of those TMJ people is, when they're talking about the interference and all this stuff, obviously you can tell they never did a single ortho case. Because if you've done 100 ortho cases, I mean, when you're unraveling that bite is so screwed up. It's at, if I did ortho and superrupted one bicuspid, so it was 2 millimeters tall, and then took all the braces off, the bite would slam that tooth back down into place in 30 days. So, I mean, so how is this, if this interference was causing all of that, then everybody's orthodontic patients should all be eating Motrin 24 hours a day.
There you go.
Yeah.
Absolutely. No, it's...
So I want to go back to the deal, but when they pointed to their masseter, so they come in and they say, where's it hurt? And they point to their masseter. Okay, why does their masseter hurt? Talk us through some cases. A dentist says a root canal, filling a crown. Talk us through your 80-20 rule. What are typical cases coming into you, and what are you doing for them?
Well, it's interesting that you say, the 80/20 rule. My 80/20 rule with actually with patients, when I let them know, and I learned this from Jim Frickton, who was really the first person that really got into oral facial pain, early 80s. He was at UCLA.
What's his
Uh,
name?
Jim Frickton, Fricton, and just a phenomenal clinician. And he said that we had dinner, this is several years ago, we had dinner, and he said something to me that I actually say to almost all my patients, which is essentially, Mrs. Smith, Mr. Johnson, I can help you, but it's 20% me, which means it's 80% you. So if the patients keep doing what they're doing that brought them into the office, whether it's clenching during the day, grinding their teeth at night, excessively chewing gum, whatever it is that we figure out is what's causing their pain, if they don't stop that, then their pain is going to continue. If they kind of follow what we do, a lot of patients, they come in. I do a lot of what we call physical medicine protocol, which is find out, obviously, if it's quote unquote TMJ, we can kind of talk about some of the neuropathic pains because that's a completely different beast. But the patients that come in for TMJ, I would say 98% of the time, I'm not doing anything with the joint. I'm not touching the joint. I'm not doing any kind of joint injections. It's muscle, and they'll tell you that it's muscle. You also have to understand the muscle referral patterns. A patient can point to their joint, but there's actually 4 muscles that will refer pain into the joint. So you have to know how to palpate those muscles. One of them is the clavicular head of the SCM. It's the deeper neck muscle. When you take that and you squeeze that, every once in a while the patient will go, whoa, that's hurting right into my ear. And I always ask, is that the pain that brought you in? I'm looking to see if I can replicate the pain. The other muscles that refer pain right into the joint are the medial and lateral pterygoids, as well as the deep masseter. Those are the 4 culprits that will actually refer pain into the joint. So even if the patient's pointing to their joint as the source of their pain, you've got to rule out muscle. And the crazy part is, with a lot of these patients, all I have them do during the day is stretch. And I've actually got a little device that I'm developing.
That first muscle was the clavicular head of what?
The sternocleidomastoid.
Okay, you said SSC. That was sternocleidomastoid.
SCM, sternocleidomastoid.
Okay.
And then, so here's where I basically take the occlusion argument, and to me, I blow it in the water in the sense that a lot of times patients are clenching during the day. They typically don't grind during the day. The grinding occurs at night, or they might be clenching at night. Always look at the tongue. If the tongue is scalloped, that's a definitive sign that that patient's clenching. They're probably doing it during the night. And sometimes when I ask patients, do you clench during the day? They're like, no, I don't think so. And I said, when you come back in a week, pay attention over the next week and let me know. And a lot of times they come in for a 1-week follow-up and they're like, I had no idea that I was clenching during the day, but they were. And so if you're clenching, if your muscles are contracted, one thing you definitely need to do is stretch. So I've actually.
But what do you mean that the tongue is scalloped? What do you mean by that? Paint a picture of that.
I can show you some photos if you want to see some photos.
Yeah. Show it. So you're saying if they're clenching or grinding, you can tell by the tongue.
Yes.
And by the way, if you're listening to this on iTunes, you can go back and see this on YouTube, or you go to the Dentaltown app. It's on the video on your podcast.
Can you see my screen?
Yeah. Oh, wow. I see the scallops. So is that clenching or grinding or bruxism?
That's clenching.
Wow.
Because when the teeth are together and the tongue has nowhere to go except it gets pushed against the sides of the teeth. And just kind of look for that on your patients, and that's a sign that that they're clenching.
Wow, that was an amazing picture. If you're listening to this on iTunes, it's you could just see the impressions of the teeth on the side of the tongue.
Right. And so one of the things I have patients do is stretch. And this is a little prototype of an appliance that I've created. You can kind of see there's a little notch on the bottom, and it's just. You do that. I have patients do that 30 seconds, 6 times a day. And the analogy I love to use are typically weightlifters, men more so than women that have been working out for years, right? They're walking around, their elbow is bent because the bicep is so contracted. What they're never doing is stretching. If you walked up to these guys and you try and straighten their arm, it's not going to happen. If you push hard, they're either going to cry or they'll cross-check you because it hurts. Couple weeks or a couple months of them just going ow, 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 and elongating that bicep muscle, the pain's going to go away. It's the same with the jaw. If they're clenching all the time, what people never have their patients do is stretch. And I get patients that are in to see me. A lot of times, some of it can be induced by dentistry. You've had a long appointment. The patient was open for 30 minutes, 3 hours, whatever it is. As dentists, we clearly get into the zone and we get focused on that tooth. We're looking in our little micron world, and we forget that there's a whole structural element related to that tooth, and the patient's just been cranked open for too long. And if you've given 1, 2, 3, 4 IA blocks, all of a sudden, they're calling you up going, my tooth feels okay, but I can't open. It really hurts to open. And it's just the muscle that's basically causing the pain. If you get them to stretch, it's going to make the pain go away.
Man, I'm a big believer in that. This is 2016. I think it was, let's see, 15, 14, 13. I think it was 12. Leaning over, looking at the patient, my neck was in so much pain that it finally got to where when I was driving the car and I looked to change lanes, it was like an electrical shock. And I had to turn my whole shoulders, and I'd always been going to chiropractors. And finally, a friend of mine, a dentist, Dr. Matter, and his wife said, you got to go to hot Bikram yoga with me. And my God, one session and driving home, I could turn my head. And when I was in that yoga class, my spine sounded like the 4th of July. And then you notice the pain moved out of your neck. Then your shoulders were all jacked and they hurt for like 3 or 4 months. And just to unravel that whole spine to undo that neck thing. So I can imagine, they're just clenching all the time. They've never stretched. That stretching device, you open up your mouth so wide, I could see Chris Farley on Saturday Night Live eating one of those big Polish sausage dogs, chanting the Bears.
When patients are stretching, I just tell them all it is yoga for the jaw.
Yeah.
A lot of people are doing yoga, but what they're not doing is stretching every muscle. These are just muscles. There's 4 main muscles that close the jaw. If you're clenching, if you're grinding, if you're chewing gum, one thing you're not doing, no one ever tells you to do, is stretch. And I have patients after patient come in and they look at me and they're like, how come no one ever told us to stretch before? And that kind of takes occlusion out of the water as the source of the pain.
Well, I would imagine that some people are afraid that if they open their jaw real wide to stretch, that it'll get stuck. Do you ever have people?
That's why it's important to get a range of motion. Have a range of motion scale. When I lecture, one of the things I teach dentists is how to take a range of motion, and it will add about 20 seconds to your exam. What I have patients do is open, just comfortably, Mrs. Smith, open without pain, take that measurement, and then open as wide as you can. So we call that the active, and then I'll push, and I'll literally just get my fingers in there, and I want to see how far I can get them open. If a patient opens, if they're opening on their own to say 55 millimeters, I never take that passive measurement. Normal range of motion is between 40 and 60 millimeters. If someone's opening in the high 50s, or if they're even looks like they're going past 60, I'll tell them to stop because their range of motion is fine. So I never want to obviously overextend anybody, but very, very few patients are going to, kind of create an open lock for themselves. Most of us couldn't even do it. If we tried, we wouldn't be able to do it. But what happens is that when patients open and they have a little bit of pain, they stop because they have pain. We typically don't like to do things as human beings where we hurt ourselves. And I just explained to the patients that you're actually doing yourself a benefit because go back to that analogy of the weightlifters, when they're stretching, when they haven't for so many years, that muscle is just elongating. It's going to hurt, but that's good pain. It's the same thing with stretching. If you know the boundaries of, and you take measurements of where you want your patients to stretch to, and you give them those parameters, they understand that this is not harmful for them. It's actually going to be beneficial. And I say to patients, when you come in, if that comfort opening isn't improved, then I know you haven't been doing your homework. And the comfort opening is that opening without pain. So they should be able to open much wider if they've been stretching.
And if you're a big fan of MMA sports or boxing, you will routinely see those guys opening their mouth and putting their jaw. I mean, they know they're about to be punched in the jaw in the face, and you will see them back there really stretching, moving their jaw side to side. I mean, they are stretching. They're moving around their mandible as much as they're moving around their arms and shoulders.
That is probably a result of trauma. One thing I don't want patients to do is to constantly, move their jaw. I just like them to do a stretch and then relax. So there's something we call the N rest. Have the patient say the letter N, ask them where their tongue is. They're going to say it's, right behind my front central incisors. Then I ask them, where are your teeth? And my teeth are apart. Good. That's where we want you to be during the day. I want teeth apart. I don't want them touching. If they're touching, it's the muscles that's going to be causing the pain, not a lateral interference on the mesial-buccal cusp of number 14.
There are people on Dental Town saying that if you make a night guard for someone because they clench or grind, that you legally would have to have them covered with a obstructive sleep apnea test, because if they're grinding, they have sleep apnea. What would you say to that? You're an expert witness. If can you make someone a grinding plate without screening them for sleep apnea?
Yes, absolutely. The evidence linking bruxism to sleep apnea is very, very weak. It hasn't, the correlation is not there. It's not something that I buy into. What you can do is you can have patients fill out, there's several different forms that you can screen for sleep apnea. You can give them the Epworth Sleepiness Scale. You can give them the Berlin Scale. There's other different forms that you can use to screen. One of the things that I do is I give patients, if I suspect they have sleep apnea, I'm going to have them do two things. I'm going to send them home with an overnight pulse oximeter so I can see what their oxygen saturation is doing at night. Every once in a while, you get surprised. I one time had a gentleman who was about 6'4", 280. He met most of the main criteria for having sleep apnea. He was a snorer. His neck size was greater than 17. He was overweight. He was male. That counts against us. It's in a big way. He actually went in and had a sleep test, and it came back he was just a snorer. So if I could bet money, I would bet money on every single NFL lineman that would have sleep apnea. But there's probably going to be 20% of them that don't. So you can't always make that correlation. There's so many people that brush their teeth that don't have sleep apnea. So if you're making that correlation that if you brush, you have sleep apnea, why are there a lot of people that brush their teeth that don't have sleep apnea? So that's where we need to do more research. But the papers I've seen, we have a American Academy of Orofacial Pain society, and someone came to our annual meeting and made that correlation. And most of us that have been trained in a residency with sleep apnea don't buy it. We just don't buy it. But you can screen for it. The other thing I highly recommend, and there's no compensation I get for even mentioning this, there's a phenomenal app called SnoreLab, SNORELAB. And
SnoreLab, SNORELAB. It's an app?
Correct.
Okay.
Just do a search, and I think it's actually snorelab.com is their website. It's on. It was only on Apple for a while. Now it's on Android. Download the app. I encourage people to get the paid version. It's about $5-6. It'll record you during the night. I always ask patients if they have a sleep partner. I'm sure we've all made the mistake of, do you have a husband? Do you have a wife? And they're like, no, I'm gay, whatever it is. So now I just use the term, do you have a bed partner? A lot of them don't. Like, well, how am I supposed to know if I snore? that's where the app comes in. Even if you do have a bed partner, the app is tremendous because it's the bed partner that's going to be suffering. So download the app. It's going to record you during the night, and you can actually see the graph of what you're doing during the night, and you can actually listen to each event if you get the full paid version.
And how much is the full paid version?
I think it's like $5, $6.
Yeah, I have to do this because I sleep with 3 cats, and they're I don't know what they're saying. Yeah, that is amazing. I never heard of that demo. Yeah,
Yeah.
that is amazing. You said you sent them home with a overnight pulse oximeter. What's the brand name?
Oh, the unit I actually have, I think they went out of business. I love it because they have a great report. But there's no
Just any.
magic to. Yeah, there's no, there's no special brand that you have to have. It's just can it record the entire night. The patient returns the device in the morning, and then you typically plug it in. I haven't found one that's Apple compatible. That most of them are all PC compatible. You plug it in, you get a report, and you can see if their oxygen is dropping during the night.
You know, an interesting thing about Apple and Android is dentists are about 80% on Apple and 20% Android. But their patients, it's almost reverse because Apple's so much more expensive. So, the average dentist makes a lot of money, so they're all on iPhones, but your average patient is on a Samsung or an Android.
Right.
You said earlier there were 2 scales to check if they had sleep apnea. One was the Berlin scale. What was the other scale?
The Epworth Sleepiness Scale,
Spell that.
EPWORTH.
So to check for sleep apnea, there's the Epworth scale and the Berlin scale.
Yeah, the Epworth, there's a third one called Stop Bang, STOP, and then BANG. I actually, if you're gonna, I like to use at least two. I typically use all three. A lot of people don't like the Berlin. So if you're only going to use two, it's nice to get both. Use the Epworth and the Stop Bang, and that kind of gives you a score.
What's your favorite?
The Epworth is pretty good, and then if they test positive on that, I'll give them the Stop Bang.
See, I would have guessed you would have gone with the Berlin scale since you were at the Berlin Wall when it fell.
Oh, that was an amazing time in history.
Well, what year was that? 1980? Or no, it was 1979. December 79?
Actually, the wall fell November 9th, 1989, and
Oh, it
after
was
the wall
89.
fell, I went to Berlin for that New Year's celebration.
Wow. I took my boys to the Berlin Wall when I was lecturing in Germany. We went to that. That's and now we're gonna get a wall now, right?
Oh, yeah.
Trump's gonna build the Trump wall. Do you think he'll build that?
Do I?
Yeah.
Since it's being recorded, I'm going to say no.
Yeah, it's not. So let me phrase this a different way. There's people saying that if you brux, that means you have sleep apnea, and you're saying not so. Well, you're in orofacial pain and sleep apnea. Is there a connection there? I mean, why are you doing those two things?
Well, it's part of the residency. It's something that UCLA added the sleep aspect several years ago for a couple reasons. One, patients with sleep apnea tend to wake up with a morning headache. What that's from is your brain is getting deprived of oxygen during the night, and you wake up with a headache. And that could definitely just be related simply just to the sleep apnea. And it's such an important service that we can provide. Most patients hate the CPAP. The course of our country was likely changed. A lot of people don't know this. Justice Antonin Scalia had sleep apnea. He took his trip, I believe it was in February of this year, to that resort in Texas. He brought his CPAP with him. It was on his nightstand in the case, unplugged. He hadn't used it the night that he died. So if he had used his device, there's a chance he might still be here. It's not good for our brains and our hearts to hold our breath or to even have a lower amount of oxygen. And here's a man, if you just look at him, he's somebody I would pick out of a lineup that say would clearly have sleep apnea. And he obviously did because he had a CPAP machine. He just didn't tolerate it. A lot of patients hate it. You're going to hear comments like, I feel like I'm trying to sleep with my head hanging out the window at 80 miles an hour. It's hard for me to have marital relations when I have to put on this device. All kinds of excuses. Those come from men as well as women. And for the patients that can't tolerate it, I always have them try the CPAP because it is the gold standard. But if they can't tolerate it, a mandibular advancement device is a phenomenal, phenomenal resource.
And what percent of your practice is oral facial pain versus sleep?
It's probably about 80-20, 80 pain and about 20% sleep.
80 pain, 20% sleep. But of that 20% sleep and 80% pain, how many of those are overlapping?
Oh, the patients that have sleep apnea, a lot of them do have pain. So
Half
there's
of,
a lot,
like
there's a
what
lot of
like what
overlap.
percent of them?
Oh, I would say well over 2/3.
So 2/3 of the people with sleep apnea have oral facial pain in your office.
Yes.
That's
So
profound.
you have to know how to treat that as well, because what you're doing essentially with a mandibular advancement device is you're contracting the lateral pterygoid. And what patients have to do in the morning, they have to do exercises. We use bite wafers. My patients call them the chew toys, but they're using these devices. And essentially what they're doing, the way you stretch the lateral pterygoid is by contracting all the closing muscles of the jaw. So it's a delicate balance you have to reach between patients that have pain. If the pain is from their superficial masseter, their deep masseter, their temporalis, the medial pterygoid, in the morning you're telling the patients to contract those muscles that you want them to stretch later on during the day. So I always recommend getting these patients out of pain first, get them comfortable, and then you can get them into a sleep appliance.
And what percent of these patients are you giving pharmaceuticals, prescription
Oh,
pills?
it really just depends. If for Orofacial pain, if we're dealing with muscle pain, I will most of the time give the patients the option of I use a lot of ethyl chloride, which is a prescription topical. It's a very, very cold topical spray. If you told me there's only one prescription that you could write to do what you do, it would be for ethyl chloride.
Ethyl chloride.
Ethyl chloride, chloride. It's used in athletics a lot when players get hit by a pitch. In baseball, clearly, if something's not broken, if they just get plunked on a muscle, whether that's the leg or the arm, the trainer will come out and spray them with ethyl chloride. It's used in cycling. It's used in all kinds of athletics, including soccer, and it can basically reset the gate. If you believe in the gate control theory of pain, it can wipe away pain. When I do my exam, if you're going to get into oral facial pain, one thing that dentists aren't comfortable doing is hurting their patients. When I do my exam with a patient, I will let them know that part of my exam is going to hurt. I'm going to let them know when that's going to be, but I'm looking for pain. What I like to say is we only treat invisible pain. So everything has been ruled out once they get to my office. Clearly, 95 or more percent of the time when a patient's having pain and they're pointing to a tooth, it's odontogenic. But once that's been ruled out, what's left? So we have to see what we can do. Can we replicate the pain with palpation of that muscle? And then if I can replicate the pain, then I want to use the ethyl chloride to see if I can reduce that pain, maybe even by half or sometimes by 100%. And because of the ethyl chloride, I've actually gotten two young girls out of a hospital. And one of them was in the psychiatric ward because there was no history of headaches. She was on week 8 of a headache. It's a really long story. I got called in. I replicated her pain with palpation of all the closing muscles of the jaw. And then I used the ethyl chloride. And I'm in the psych ward. I had to get buzzed into 2 doors. And it's a weird feeling knowing my card doesn't let me out. They have to let me out or I'm locked in there. I used the spray. Her mom was there, her sister was there, and there was a nurse there. I used the spray. Before I used it, I'm like, where's your pain? Left is a 3, right's a 6. I used the ethyl chloride, waited a few seconds. What do you feel now? And she says, as the eyes kind of roll back into the top of her head, left is a 0 and the right's a 3. And the nurse literally mouthed the words, So I know people on the podcast can't do that, but it's basically 3 words.
WTF?
What the heck? And it was just this girl had been clenching for 8 weeks and no one picked up on it. She had MRIs, MRAs, MRVs. They did a spinal tap on her. Physicians never think muscle, and not enough dentists think muscle as the source of pain.
Well, I think the craziest thing about every hospital in America is you could go in there with a brain tumor, they could remove it. You go there with a clogged heart artery, they could remove it. Yet they can't take a PA and look at a tooth and pull a wisdom teeth. I literally, you can't make this up. I've had patients come into my office with a 2 foot by a foot and a half X-ray of their head, and they, I mean, for a toothache, from
Yeah.
emergency rooms in Phoenix, and you go in there and you have a horrible toothache. They just give you Vicodin, Pen-VK, and turn you loose. It's like, if it's 8% of their emergencies, why doesn't every hospital have a dentist in a chair to look and screen and be able to pull an infected tooth or start a root canal? I mean, it's just, I mean, why? How come they can remove a brain tumor and they can't remove a wisdom tooth?
You're preaching to the choir.
I mean, it's just literally insane. Hey, I want to ask you a whole nother. I want to change topics completely. We hear a lot about trigger point injections, the use of Botox and facial pain. What is your thoughts of all that?
First of all, you got to find the source of the pain. Can you replicate the pain? If you can replicate the pain with, palpation of a muscle, great. So the conservative way of doing that is to, do that, what we call that physical medicine protocol, stretch. I have patients take a leave, 2 tablets twice a day. For those patients that can't take any type of NSAID, there's actually a very, very good double-blind study on an over-the-counter plant called, the medication is called Boswellia, Boswellia, and we have them take that 300 milligrams 3 times a day and stretch. And obviously, if they're clenching and grinding, then you need to make them an appliance at night and have them stretch. If that is not helping sufficiently or not at all, then I'll do trigger point injections, but I'll use 1% lidocaine. What a trigger point is we're basically trying to find that hyper irritable spot. We go in there with a needle, 1% lidocaine. I basically, I'm trying to find those little knots. And I go in, like let's say you're doing the belly of the superficial masseter. 2 fingers in from the angle of the mandible, or you can have the patient clench and your finger's going to pop out. That's where the belly is, and that's probably going to be the main source of superficial masseter pain. So I go in there, I deposit about 1/3 of a cc, I kind of move a little bit laterally, a little bit medially, and deposit the other 2/3 there. So I basically have 3 spots where I've injected 1/3 of a cc of 1% lidocaine. And then I go in there and you're basically just, we call it salt and peppering. You're just going in there and you're moving the needle in and out. And a lot of times, I did this yesterday, and the patient, it was like, I kind of feel a crunching. And what you're doing with the needle is you're inducing inflammation. In some states, not in California, but in some states, physical therapists can do this. It's called dry needling. They don't have a license to inject, but they can just go in there with the needle. With lidocaine, the patient's going to get a benefit if that is the proper diagnosis right away, literally within a minute or two. But the lidocaine, we all know, is only going to last for about 2 hours, give or take an hour. The benefit comes in within the 24 to 48-hour period as the body starts to repair all of the inflammation that we're inducing with the needle. And I've got a patient coming in this afternoon. His spot was on the medial pterygoid. I wasn't really sure if it was either nerve pain or muscle pain. I did a trigger point. If it's nerve pain, the anesthetic is going to work, but it's going to wear off right away, and the pain's going to come back. It actually lasted for him 8 days. So you're not going to be able to block a nerve, as we all know, for 8 days, and it was just muscle pain. So with him, I'm going to repeat it. I want to see how long I get the second time. With some patients, when you do a trigger point with lidocaine, it's one and done. That's one extreme. The other extreme is It works for a few days, so you know your diagnosis is correct, but the pain's back. I'll repeat it. The second time, again, that might be the second one, could be all they need, or they might get a week's, several weeks, or a couple months relief from that. And the other extreme would be it worked, but it's back. At that third appointment, that's when I'll go to Botox for those patients. If it works, but the pain returns within a few days, you repeat it, the pain returns again within a few days, that's when I use Botox. So I use Botox, but I use it last. I think these courses where they're just telling patients to squirt some Botox in there, it's going to wear off in 3 months if you're not right. It's really expensive, and I don't see the upside to using that first as opposed to going to something that's extremely inexpensive and very, very conservative that might do the same thing as Botox.
Change subjects again. How do you recognize the signs and symptoms of trigeminal neuralgia?
Oh, it's actually, the patient will tell you. If the patient ever talks about electrical pain, sharp shooting jolts that's intermittent, that completely goes away, my money is never on the tooth. I've got case after case where patients come in. One of my most recent cases, a gentleman came in, had a crown and an endo on number 2. Number 3 and number 4 were both implants. Number 5 was a crown endo, and he still had the exact same pain. I was able to replicate his pain by what we call dynamic allodynia. It's basically taking a Q-tip, and I pressed on the buccal gums where he said his pain was. It was right between 3 and 4. I pressed hard on there, and it kind of made him jump. It gave him that electrical shock. And then I was able to block his pain simply with topical. Well, you can't block tooth pain with topical. So all that dentistry that gentleman had was completely unnecessary. I told him, my diagnosis was trigeminal neuralgia because he came in talking about this sharp shooting electrical pain that completely goes away. And for those people that are on the video cast that have never seen anybody with TN, it looks like this when it hits. It's a really high, sharp spike. Some of them, they're not all high, but they have varying intensities. But the pain completely goes away, and it typically doesn't wake the patient at night. We all know with odontogenic pain, if it's a tooth pain, it loves to wake the patient at night. And it's just this constant freight train of a throb. It's just going to keep coming and coming. Tooth pain typically doesn't disappear. I told him I wanted to get an MRI. He said he'd already had 2. And I said, and they were both normal. And I said, well, no one instructed the radiologist to look for what we call the vascular loop protocol. I wanted them to trace the trigeminal nerve from the brainstem into the brain to see if there was one of 2 arteries that were touching the nerve that can account for the pain. And it's typically either the posterior cerebellar artery or the anterior inferior cerebellar artery that's touching the trigeminal nerve somewhere along the track, and it's just wearing away at the myelin sheath, and that's what causes the pain. So again, if a patient ever describes, electrical jolts, jabbing type of a pain that completely disappears, my money says it's not the tooth, and that's definitely something you have to get an MRI for, because you want to rule out any type of space-containing lesion, multiple sclerosis, acoustic neuroma, or something like that.
Well, we went 5 minutes over our hour. We're lost into overtime. What if some of these kids are listening to this and you're speaking way over their head, and they say, "I'm interested in this area." Everybody walks out of dental school with the same complaint since the pyramids, that they didn't learn everything they wanted to learn in dental school. Every dental student complains they didn't do enough endo or Invisalign or whatever. So if you're a young kid and you're just listening to this and say, "Man, Rich, I wish I knew everything you were talking about," what would be the stairs up the stairway? Where would you start the curriculum how to learn everything you're talking about?
If you want to learn from a text, there's a great text called Bell's Orofacial Pain, and it's Orofacial. It's one word. It's
the book is called Text Orofacial Pain.
It's called Bell's, Bells.
Can you find that term? Bell's Orofacial Pain?
Correct. You can get it on Amazon. Dr. Bell died several years ago. The new editor is Dr. Jeff Okeson. He's the head of the Orofacial Pain Program in Kentucky. They've got a great continuing education course. UCLA has a very, very good, what we call a mini residency, where you can come and spend, it's 5 months, but it's only a day and a half a month. It's a all day Friday, half a day Saturday for 5 months. So it's only about 7.5 hours, but you're actually in the clinic. You're not treating patients, but you're observing the residents as they treat patients. And you get to see what these, these patients go
And
through.
that's UCLA.
That's UCLA.
That's nice. So
New,
five weekends over 5 months, day and a
yes.
half, and that's called the UCLA mini residency in orofacial pain.
UCLA Orofacial Pain Mini Residency.
Oh, well, that'd be an excellent start.
Yeah, they also have a mini residency in sleep, which is separate. So, one of the things that I always hate when I hear that a dentist, oh, I'm making sleep appliances. A lot of these guys and girls think it's like placing a crown. You do your restoration, you have them in for the 1 week check, the tissue looks good, you're done. Sleep appliances require constant monitoring. You have to see the patient. You want to see them at 1 week, 1 month, 3 months. You want to make sure that your device is properly adjusted. If your airway's not open, then you're actually doing them a disservice because they think they're, trying to help manage their disease. But if the airway's not open and that oxygen's not flowing, then you're really not doing any good. So you really have to know what you're doing. You got to follow up with the pulse oximeter, and you want to follow up with the snore lab. Make sure that they're getting good oxygen at night, and make sure that they're quiet. And then, if they did previously test positive for sleep apnea, you definitely need to follow up with either a home sleep study and a sleep center study. And there was a podcast. You had a gentleman, I think it was Koala Sleep Centers, the name escapes me.
Right.
He's right on. As dentists, we are not legally allowed to diagnose sleep apnea. So you have to have that done by a sleep physician to get that diagnosis.
Yeah. Now, are you involved with these two UCLA residencies?
I'm actually a clinic co-director for the residents. I'm there every Wednesday. So on Wednesdays, I typically give our residents a lecture for an hour on headaches, facial pain, whatever it is. And then in the morning and afternoon, I cover the clinic. I'm not associated with the mini residencies. As you know, I do a lot of cycling, and my time to cycle is on Saturdays and Sundays.
Well, you could switch from bicycling to motorcycling, and then at the end of the lecture, just jump on the Harley and cover the same distance.
If I ever got a motorcycle, my mom, who's still alive, said she would kill me, so I don't want to find out if she was joking or not.
Oh my God, yeah, that's I just saw an ad for a BMW motorcycle, and it's got augmented reality glasses to help you with curves and dangers and all that. And the BMW ad said that 5,000 humans die each year on a motorcycle.
Wow.
And this is their response to try to make it safer. But I saw that number and I thought 5,000. Personal question on that. If you got on a motorcycle, your mom would be very upset. And I have 4 boys, and I told them no. Even though I'm not paying for anything anymore, I just said no. But then you take out the engine, and now it's a bicycle and you're pedaling. But 700 Americans get ran over on a bicycle and killed every year. 700 a year Americans killed on a bicycle. How do you rationalize your mama wouldn't let you on a motorcycle, but why is she good with a bicycle? And do you get creeped out a lot? Because I did 3 Ironmans in a row, and I swear to God, I get creeped out. If I'm biking for more than 50 miles, I'm going to have one incident where I'm like, I didn't like that with cars. How do you share the roads with the cars on a bicycle?
Well, I'm fortunate. I live in LA, and I'm very, very rare species in the sense that I actually put more miles on my bike each year than I do my car. That says a couple things. One, that I live fairly close to my office, and I don't have to deal with the traffic. It also says I do a lot of cycling, and I do my cycling as much as I can with other people. We have a Sunday ride. The club is called Velo Club Lagrange. If anybody in the Los Angeles area, or even if you're visiting, come join us. We have a Sunday ride. We typically have 75 to 150 people. And when you're in a train like that, like if the front people roll through the light, everybody else rolls to stay together, and it's much safer in numbers. I've actually been hit twice. One of them ended in a back surgery of mine. I was rear-ended by a van at about 45 miles an hour. It's a risk. I definitely know it's a risk. I think it's just something that so much of it we can't control. Everyone's texting and driving and they're not paying attention. And all it takes is somebody obviously to not pay attention for even just a millisecond, and they can take you out, either injure you or kill you. We know the risks. I personally, I've never had the drive to get on a bike with a motorcycle. Cycling, I enjoy the aspect of the camaraderie, the exercise. My longest ride was from Los Angeles. We rode up to Santa Barbara, which was a little over 100 miles, and we rode back. So it was 250 miles.
Oh my God.
So
nice.
It's just the enjoyment of going out there and riding, and it's just something that I love. And I actually don't start Tuesdays and Thursdays until 10 o'clock so I can get in a morning ride with my friends.
Yeah, you know how I rationalize it in my walnut brain is that, okay, 700 people get killed on a bicycle each year, but 500,000 drop dead of a heart attack. And then I think, hey, what's more likely to kill you, Howard? Being a short, fat, bald Irish guy dying of a heart attack, or on your bicycle? So that's how I rationalize it. They're both, it's just the heart attack is an immensely greater risk than getting hit by a bicycle.
We gotta live,
Yeah.
and you got to do what you enjoy. Some people, get their enjoyment working out in the gym, indoors. Some people get it outdoors at different things. Just get out there and get some exercise. Like you said, it's the heart attack is going to be more likely to kill you than a car on a bike.
And hey, I know UCLA probably doesn't need any marketing. Their reputation astounds them. But you and I are the generation. When I said, "How do you learn more?" the first thing you said was a book, Bell's Orofacial Pain on Amazon, and that's old school. You and I. These millennials, we put up 350 some courses on Dental Town, and they've been viewed now coming up to 700,000 times. They watch it on their iPhone, their iPad. They just like online CE. But if you guys at UCLA or any of those mini residencies on oral facial pain or sleep, put up a 1 hour course or a teaser course on your center, I bet it'd be the best damn marketing they ever did for their deal. So you could do it, or you could spread the word with those guys. But online CE is where it's at. And what I love about it is, I got an email this morning. I swear it made me almost cry. It was from a guy in Lagos, Nigeria. And he said, because we make our online C courses free in the third world where, they don't have the money for that. And he just says that, he just can't believe it. He has this kind of access to information. I remember when I was in a dental office in Somalia and Ethiopia, and these, anytime I see a dentist, I walk in there. And these little Muslim girl dentists were telling me that it was just the greatest thing in the world. That they could never in their lifetime afford to fly to UCLA and do a mini residency. And here they're on their Samsung watching all these courses, and they just tell me they learned so much. So if you ever get some free time, it'd be awesome to have some a mini residency on that stuff on Dental Town Online C, because you're talking way over a lot of people's heads right now.
Right. Yeah, and we're actually I had mentioned earlier the AAOP.org, which is the American Academy of Orofacial Pain. Our annual meeting is at the Walking Stick Resort in your backyard in May.
Walking Stick, is that
I believe it's in Scottsdale.
Yeah, there's two. There's Arizona Casino Arizona, and then Walking Stick. Talking Stick. Yeah, Talking Stick.
I thought it was Talking Stick.
Yeah, that is a really nice hotel, because it's got they have balconies out there, so you can see the mountains and the Superstition and Camelback, and oh my God, that's a beautiful place. So when is that?
I believe it's May 4th through 7th of 2017.
Okay, well, I hope I see you in person at that meeting. When you're in town, give me a call.
I absolutely will.
Okay, I'm Howard at dentaltown.com. Thank you so much, Rich, for spending an hour today with my homies. That was just amazing.
My pleasure.
All right. Talk to you later.